start.
Good morning, Dr. Manu sir, Dr. ADITYA sir. I am presenting a chart of psychiatric emergency. First, psychiatric emergency is suicide. The risk factor that predispose to suicide are death, divorce, job, finances, recent humiliating life event, mental illness, mood disorder, and schizophrenia. Most common method of suicide is hanging, poisoning, drowning, self-immolation in young women. Management of suicide is suicide watch, avoid excessive suicide tools, and suppress the drug. Treatment of suicide is ECT and benzodiazepine. Second, psychiatric emergency is violent patient. Associated factors are alcohol and substance abuse, schizophrenia, paranoid psychosis, head injury, intoxicated hematoma. The psychosocial factors are in young male less than 40 years, unemployed male, low socioeconomic status, marital issue, and past history of violence. Signs predicting impending assault is demanding immediate attention, loud voice, staring eyes, flushed face, hands clenched, and uncooperative. So management in violent patient is injection haloperidol, chlorothiazide to calm the patient, injection lorazepam, psychotherapy, injection haloperidol plus benzodiazepine, injection lorazepam, injection diazepam, and injection mirazepam. Third psychiatric emergency is rape and sexual abuse. Rape is the forceful coercion of unwilling victim to engage in a sexual act, usually sexual intercourse, although anal intercourse and fellowship can also be acts of rape. Rape is a life-threatening experience in which the victim has almost always been threatened with physical harm, often with a weapon. In addition to rape, other forms of sexual abuse include genital manipulation with foreign objects, infliction of pain in post-sexual activity. Typical reaction in both rape and sexual abuse can include shame, humiliation, anxiety, confusion, and outrage. Fourth psychiatric emergency is panic attack. So panic attacks are characterized by unreactive, irrational phase of anxiety of excessive intensity, worrisome thoughts, avoidance behavior, and domestic symptoms of autonomic arousal. Clinical features in panic attack are muscle tension, bowel distension, sleep disturbance, difference in conversation. Treatment of panic attack is benzodiazepine, mouth-dissolving clonazepam, azathioprine, bupropion, sedative is hydroxyzine, barbiturate is amlodipine, relaxation technique is also treatment.
Okay, thank you, Dr. Nancy presentation. Now, please.
Good morning, Manu sir, and good morning, ADITYA sir. I will continue the further psychiatric emergency. My name is Fifth psychiatric illness is substance abuse. Definition is inability to stop using a substance behavior even though it is causing harm. Clinical features are poor performance, lack of energy, weight loss, palpitations, inability to maintain hygiene, irritability and angers. Etiologies can be emotional stress, post-traumatic, peer pressures, pleasurable feelings and depressions. So there are types of substance abuse can be done. There is alcohol, tobacco, LSD, marijuana, cocaine, and treatment for that are anti-addictive drugs, multivitamins, psychotherapy, cognitive behavior therapy, and rehabilitation. Sixth is alcohol withdrawal syndrome. Definition for that is alcohol withdrawal syndrome is characterized by central nervous system hyperactivity that occurs when an alcohol-dependent individual abruptly stops or significantly reduces the alcohol consumption. Symptoms for that are common symptoms seen in the patient is nausea and vomiting, headache, excessive sweating, fatigue, unpleasant and vivid dreams. Severe symptoms can be severe disorientations and confusions, seizures, fever, high blood pressure, and extreme agitations. Stages of the alcohol withdrawal symptoms are mild stage, which contain anxiety, tremors, insomnia, headache, and palpitations. Moderate stage contain mild symptoms and diaphoresis, increased systolic blood pressure, tachypnea, and confusion. Delirium tremens contain moderate symptoms and disorientation and seizures. So treatment for that is supportive care, thiamine, electrolyte management, folic acid. Pharmacotherapy contains benzodiazepam as a first-line treatment for the alcohol withdrawal, and non-pharmacological management contains supportive care, nutrition, and fluids. And others contain convulsions disorder, hysteria, which contains hysteria, which contain brief routine. Side effects of psychotherapeutic medicines are dystonia, extrapyramidal
hyperthermia.
Other features include myoglobinuria, raised
CPK.
level, total WBC count is raised. Treatment for that is bromocriptine, amantadine, and
Dentoline and
electrocompression
ECTs.
therapy.
Okay, thank you, Dr. Nice introductions. Okay. Dr. Aditya will say some things regarding psychiatric emergencies. As a psychiatrist, right?
Good morning, Dr. Manu sir. Today we are going to have a session about psychiatric emergencies. So, what exactly are psychiatric emergencies? So, it is a particular condition where immediate care is required, otherwise it will cause a sufficient or a significant harm to the patient or to the surrounding people. So, we are talking about a lot of psychiatric emergencies today, as mentioned before. The first and the most important one is suicide. Now, suicide attempts, as we all know, are increasingly common nowadays, and there are a lot of reasons for that. Okay, when a patient with suicide comes to emergency department, the first thing what we ought to do is first we will check whether they are vitally stable or not. If they are not, directly we need to first take medical management for the patient. We need to stabilize the patient before giving any psychiatric care to the patient. If patient is vitally stable and still patient feels he or she is suicidal, then it is the job of the psychiatrist to calm down the patient and to know what is the reason for that, right? There may be multiple reasons, as mentioned. There are grief or particular acute stress reaction. There might be a lot of reasons for suicide, depression, MDD, or under influence of any substance. So we need to take that into consideration. The first thing we do is de-escalate. Verbal de-escalation is preferred over pharmacotherapeutic. We need to calm down the patient, make him talk, vent him or her out. And even if still the patient is suicidal, actively suicidal, then we can use some benzodiazepines to calm down the patient. Even after that, if the patient feels or he or she is suicidal, we have two major modalities for highly suicidal patients, that is ECT, one, and the second nowadays what we are using is ketamine as well. Ketamine therapy is very useful in severe acutely suicidal patients as well. So that can be done. The second commonly presented symptom in emergency for psychiatric doctors is violent patients. There are usually a lot of calls regarding violence. Now again here, the main job for the psychiatrist is to understand the reason for the violent behavior. Is it some illness? Is it under the influence of substance use? Or is the patient has the personality disorder like antisocial personality disorder, which makes him violent as well? So the finding the cause is very important before starting any treatment for that. Now, if we find the cause, the most common usually arise to be schizophrenia or bipolar mood disorder, which is mania. Here, first choice what we do is we can again psychologically de-escalate the patient. Then we can use some antipsychotics like haloperidol and then promethazine as well, which can calm down the patient. Hopefully, we can initial treatment can calm down the patient, and then we can start our treatment based on the diagnosis of the patient, whether it is schizophrenia, whether it is bipolar disorder. And if the patient is acutely intoxicated, again here we can restrain the patient. Usually in intoxication we do not prescribe any treatment because already the patient is under the influence. More psychiatric treatment can cause some depression, restraint depression also. So usually restraint is the first line of management here. Okay. Third, we have mentioned is rape and sexual abuse. Now here again the psychiatric diagnosis of rape and sexual abuse victim is acute stress disorder. The acute stress disorder the patient presents with again can be either a suicidal attempt, it can be shame, guilt, not talking, or a conversion reaction which can include mutism or tightening. So again here the first line is psychological de-escalation of the patient. Secondly, what we can do is prescribe some benzodiazepines initially to calm down the patient, and then we can talk to the patient. And usually for acute stress reaction we usually start some low dose antidepressants, and monitor the patient to see whether he or she has any signs about warning signs about suicide or so. If that we need to keep patient in close monitoring. We need to counsel the family members. We need to keep patient away from some harmful weapons or knives or any potential threatful objects which the patient could use. So we need to take that into consideration as well. Now, panic attack is one of the most common presentations for psychiatric emergency. Usually the patient presents with complaint of chest pain, breathlessness, sweating, palpitations. So firstly, the patient directly goes to the physician because of thinking that they might be having a heart attack or they might be having some acute respiratory illness or so. But after getting all the routine investigations which come back normal, they are usually referred to the psychiatry department. And here again, what we do is we give them benzodiazepines for immediate management of the panic attack symptoms, and usually we start some antidepressants, usually SSRIs like sertraline, fluoxetine, escitalopram, along with some benzodiazepines for use whenever there is another precipitating panic attack. The fifth is substance use. Now, usually substance use itself does not present within psychiatric emergency. It is either intoxication or withdrawal which presents to an emergency department. So, as we mentioned, the withdrawal is mentioned later. We can talk about intoxication. Now, there are a lot of intoxication substances which usually then precede towards a violent or uncontrollable behavior. Usually it is alcohol, which is most common around this area, and there can also be cannabis use, there can also be opioid use. Now, opioid use, intoxication, again it presents with a different type of symptoms, because in that case there is depressed, patient is slightly stuporous, they are unconscious maybe. So that time again it goes into medical management. For alcohol use, patient may be irritable because of the disinhibition. So here we need to restrain the patient. If necessary, we can prescribe some low dose antipsychotics for immediate calming the patient down. And later, once patient stabilizes, we can counsel the patient for alcohol de-addiction or whatever the next line of management for alcohol use disorder is. Alcohol withdrawal syndrome is very important to manage. Again, it is very commonly seen here and very commonly presented in the psychiatric emergencies. Usually the patient maintains some abstinence for 1 or 2 days, or the patient might have reduced the amount of consumption of alcohol and then presented with symptoms of restlessness, anxiety, palpitation, tremors, like similar symptoms to panic attack. Again, if patient has been consuming large amounts of alcohol and has stopped it suddenly, there may be risk of alcohol withdrawal seizures as well, or the patient may directly present as in delirium, that is known as delirium tremens, if it is due to alcohol withdrawal. Now, here psychiatric management is very important to prevent further alcohol withdrawal seizures or to prevent worsening of the delirium. So usually the first line of management here is, firstly, patient is still not cooperative. We need to restrain the patient. We need to give some benzodiazepines, which is the first line of treatment. Usually lorazepam injection is preferred here. We can also give chlordiazepam, diazepam, and along with that, thiamine is very important to prevent the patient going into Wernicke's encephalopathy or post-psychosis psychosis. And also fluid management, because the patient has not been eating or drinking, there might be some hypovolemia, there may be reduced hypotension, so we need to take that into consideration as well and correct those electrolyte abnormalities as well. And there are a lot of other emergencies as well. The one mentioned is conversion disorder or hysteria. Usually it is the physical symptoms due to a psychological cause. So usually symptoms which are very common in conversion disorder are either convulsions, which is also known as PNES, that is psychological non-epileptoid seizures, which are seen in usually the age group for conversion disorder is young adult to adolescent people, and usually seen in females more than males. So they usually present after some acute stressful situation which has occurred, and then such symptoms present. So again, some other ways of presentation of conversion disorder can be mutism, it can be sudden unconsciousness, it can be seizures as mentioned, it can be paralytic like symptoms. So we need to firstly again we need to rule out all the medical causes for all those symptoms. If that is all come back normal, then we can proceed and we can put the diagnosis of conversion disorder. We can first line of treatment again is benzodiazepine, and then we can start some low dose antidepressants for further treatment and prevention of further such episodes. There are again some medicine-induced syndromes as well, which include NMS or neuroleptic management syndrome, which is a very rare kind of a symptom, which is seen when there is some adverse reaction to one of the antipsychotics. Usually it is the first generation antipsychotics, and the patient presents with delirium, rigidity, hyperthermia and all. And here it is a medical emergency. We need to transfer the patient into a medical unit, maybe an ICU unit as well. We need to give IV fluids, manage the hypotension. Here we need to prescribe some dopamine agonists to help with the symptoms like bromocriptine, amantadine, and dantrolene is a drug of choice if required. And if it is still untractable, then we have the option to give ECT for the patient, which has a good prognosis with this treatment. So that's it with all the psychiatric emergencies. There are a lot more, but these are some which are explained.
Thank you, Dr. Aditya. Nicely presented all psychiatric emergencies. Thank you, Dr. Viren. Okay.